always, I have my gratitude towards the whole nursing fraternity for giving me an opportunity. Well, it is much deserved as well, I believe, since the punchline of the whole nursing conclave is quality in nursing can redefine healthcare. So even though it's the last topic of the day, but I see a room full of enthusiastic people, wonderful ladies and great gentlemen. No wonder the temperature is soaring high thanks to you people. Well, I would like to keep up with the enthusiasm you have till the last second of this presentation. I have been given a very good topic of standardization of quality indicators. Well, this happens to be one of my forte and an interesting area of my personal interest, since being a quality professional from the beginning of my career, I have actually come a long way in basically working for, deriving, and also getting some analytical expert advice for the management to help take a good decision in improving the service quality for patient care. So here we go, ladies. Golden words from Dr. Guru N. Reddy, Chairman, Continental Hospitals, about quality in healthcare delivery should be a way of life demanding quality at source of infrastructure, technology, manpower, physician engagement, effective strategy, and vision. It's the only way to ensure safe, preventable, errorless, and uncompromising care to our patients, guests, and their families at all times. These words are just not for the namesake, or we just write it over the placard and feel happy about presenting it, but we actually mean it in letter and spirit, and we practice it day in and day out. Thanks to the great foundation laid down by the chairman and implemented by great patrons of quality in this organization, especially the backbone of quality in this organization, the nursing department. Well, significance of quality in healthcare. Knowledge of quality management in hospital can go a long way in improving the standard of healthcare services. We all are quite aware of it, since I have actually come across a lot of examples today in the session about who not. But I would like to quote again about Miss Florence Nightingale. When I say Miss Florence Nightingale, I actually see her soul in each one of you, the spark in each one of your eyes, because she was the one, she was the pioneer because of which nursing has become an important, significant profession in healthcare. I would not like to start the debate again about what we discussed in the afternoon, but let me tell you, in this healthcare fraternity, I have my greatest regard for nursing profession, and thanks to people like Florence Nightingale, who were actually born, and not only born, but did share their experience and knowledge and made it quite useful till today. Isn't it? Till today's era of 21st century. So what does her knowledge tells us? Ma'am, one of the conveyors and moderator of the debate, mentioned that Florence Nightingale was a great statistician. So what did Florence Nightingale actually do? She did not only implement great service, and she did not only implement good practices, but also did make a note of documenting it and also making it available for the forum at large by publishing, by actually bringing it to the knowledge of the utmost significant fraternity of healthcare, that is the doctors, because she had the confidence and she was right about what she was doing and what she was actually practicing. So for basic example, which we still practice or which we still try to implement, but we haven't yet completely achieved it, is the example of hand hygiene practices. My friends, for hand hygiene practices, when I quote this example, I would just like to bring a small piece of information to you all, is that when she implemented the basic hand hygiene practices at the time of World War II in the war-ridden Second World era, in the soldiers' camp, when she realized that basic sanitation is actually marring the patient care and is the basic or main reason for the high mortality rate, when she implemented hand hygiene monitoring in her nursing care, the result was actually, it was amazing. From 48% of death rate, mortality rate, it came down to 10%. And then she was able to make it popular or make it practicable by everyone is because she actually documented it. She put her knowledge into documentation. So let us have a look at about an old saying which goes by, knowledge without practice is sterile, but practice without knowledge is blind. So be knowledgeable, be informed about what you are doing. That's how you can bring a change, my dear friends. We work in the most complex world. How complexity in healthcare has increased. I would just like to show you an abstract from the Checklist Manifesto by Dr. Atul Gawande, where he mentions that we live in a world of great and increasing complexity, where even the most expert professionals struggle to master the tasks they face. Longer training, even more advanced technologies, neither seems to present grievous errors. However, in the immensely complex world of surgery, a simple 90-second variant has cut down the rate of fatalities by more than a third. Well, this is a forum for nursing, so I will not go gaga about a doctor. However, it is worth mentioning that the Checklist Manifesto is almost synonymous to the Surgical Safety Checklist by WHO, isn't it? So what does the Surgical Safety Checklist do? It simplifies things for you. It makes it error-less or zero error at the most complex and critical area of healthcare, that is the surgery. So that is the significance of documenting and preventing errors in healthcare, by which even the most complex procedure as a team can be performed with great excellence and zero defects, isn't it? Well, we are in the era of quality revolution. This decade is actually seeing a lot of revolution in quality because we are now changing the turn of the wheel. The quality revolution, as it is sometimes referred to, is nothing but putting the patient at the heart of healthcare and wrapping the care around it, rather than the other way around these days. The next decade, however, shall see a great change in the healthcare sector, and there is a need for standardization of healthcare delivery at all levels. We do agree with this, which at the moment is lacking, especially in a backward country like India. I am quoting India as a backward country, even though my hospital is JCI, because in this forum, maybe I can give you some thought-provoking insight about where we are and where we want to take it to the next level. There are various ways of achieving quality in healthcare. Some of the very popular 5 ways of achieving quality in healthcare with their limitations and their significance. Here I have tried to jot down 6 Sigma. May I please ask the audiences, how many of you are 6 Sigma certified? I can see 1, 2, 3, 4, 5. Well, for a room full of 300, 5 is a significantly less number. Even I am not a 6 Sigma certified person. Let us see why it is not so popular amongst the healthcare professionals is because of its limited application in hospital due to its complicated data-driven mathematical approach, which I had a discussion and deliberate discussion with one of the 6 Sigma certified person here available in the forum, Ms. Josephine. Next way of achieving quality in healthcare is lean thinking, that is by process improvement approach, but it may not be adequate as a holistic system because lean only talks about reducing the errors and actually culling down all the unnecessary things. But what about bringing a change? What about implementing something? Lean actually does not fulfills those criteria which are very much required for a profession like healthcare, because without knowledge, healthcare cannot practice. Next is the ISO system. ISO system happens to be the mother of all accreditation, certification, and quality improvement projects and whatnot in not only healthcare but across all the industries. It is a pioneer, it's a leader. However, it has not evolved. The system of certification has a shortcoming of no prescribed quality standards of its own. What you document is what you practice, and that is enough to get an ISO certificate. Hence, it is not so much sought after by most of the hospitals these days. TQM, Total Quality Management. It is a widely accepted system of quality management, but it is all about customer satisfaction. However, it has still not got the advantage of accreditation. So what is the best way of achieving quality in healthcare these days? And the most popular way is to implement or to vouch for accreditation, isn't it? The focus of an accreditation is on continuous improvement in organizational and clinical performance of health services, and not just the achievement of certificate or award, or merely assuring compliance with minimum acceptable standards. Now, how do we understand this? Is because the accreditation process is to be maintained for a certain period of time, and then you have to go for re-accreditation. In fact, NABH for that matter, it does not only goes for re-accreditation, it goes for midterm accreditation also. So you need to compulsorily maintain the standards that you have proven that you are achieving, or you are maintaining, or you are complying by, and at the same time you need to carry it forward also, isn't it? So how do we maintain accreditation? Is by implementing certain standards and guidelines given by the accreditation boards or the authorities, or the people who are behind the technical know-how of these standards. Now these standards need to be implemented, and later on these standards also need to comply with. But how to comply and whether we are complying or not is a judgmental issue. Now, not to make it subjective and to make it very objective, we need to actually measure these standards, and the measuring tool of standards is nothing but the quality indicators. So monitoring healthcare quality is actually impossible without the use of clinical indicators. They create the basis for quality improvement and prioritization in healthcare systems. The indicators assess particular healthcare structures, processes, and outcomes. And the indicators can be rate-based, mean-based, providing a quantitative basis for quality improvement. They can assess aspects of the structure, process, and outcome of the healthcare given to the patients. So everything about quality indicators, everything about implementing standards in an accreditation process boils down to, or keeps at the center, the patient care, isn't it? So that is the significance of quality indicators in healthcare and accreditation process at large. The interest in quality of care has developed in response to the recent dramatic transformation of healthcare systems, accompanied by new organizational structures and reimbursement strategies that may affect quality of care. These days, CGHS is giving higher rates to an organization which is NABH accredited. So that is the significance of an accreditation process. And we all know that if we want to maintain accreditation process, we need to comply by the standards and also to evaluate ourselves. Evaluation is nothing but monitoring of the quality indicators. So what happens there if there is an absence of quality indicators? Well, there will be a lack of documentation about how major illnesses are treated in most healthcare systems. There will be a lack of systematic outcome assessment. There will be a lack of resource evaluation related to quality for specific diseases. There will be persisting variations among providers in care for similar patients in different settings, and that there will be few formal monitoring systems which are in place by healthcare providers or regulators if there are no indicators being monitored. For most diseases, this is the scenario of India, very sorry status of affairs right now we have, that for most diseases, potential quality problems and their prevalence and incidences are unknown in many countries. India happens to be one, but I, as a quality professional who started working in the year 2008, and when NABH board was formed in the year 2005, had started working from the first edition of NABH standards itself, I am quite hopeful with their modus operandi and their way of approaching towards these quality indicators. I'll be talking about it as well as about the quality indicator monitoring process in JCI. Anybody who would like me to define the quality indicators, or in the interest of time, maybe I can skip it? Okay. Well, the ladies at front who have been given the task of complying by time are suggesting me not to bore you audiences with the definition of quality indicators in letters. However, I think I have made my point by telling you the significance of indicators. Positive implications of quality indicators. Now, here is where I would like your attention to be put. It helps us to document the quality of care at large. It helps us to make comparisons, to evolve and to set benchmarking over time between places, that is between two different hospitals or within the same hospital or like those hospitals which have group, they can come up with their own internal benchmarking for the group or the organization, which is spread across different locations. So that is the significance and importance, a very beautiful part of quality indicators. That is where, like, you know, I became very interested about these quality indicators, because they give you a lot of information. They give you a lot of information beyond your day-to-day practices in the long run. They support accountability, regulation, and accreditation. Of course, we have to comply by the CQI chapter of NABH and QMS chapter of JCI if we want to stick around and if we want to maintain our accreditation. So accreditation cannot be achieved without monitoring quality indicators. That is my experience. They support quality improvement and support patient choice of providers, because of course in the morning when I was listening to the principal secretary of APMCI, I was little intrigued when he mentioned that, you know, the number of patients in Osmania Hospital or any public hospital is much more than the number of patients you serve in a corporate hospital. Well, his vision and his perception is totally personal and is true to my knowledge as well. But if I compare or if I see the performance or the choice of healthcare buyers, when they can pay and afford, when they have to go for a hospital, they definitely want not so crowded hospital. They want clean, well-maintained and crowd-managed hospitals, because as we all know that there is a health risk involved with the crowd, isn't it? I would not like to anyway start up another topic of debate. So that is my perception. Now, while you are deciding about your quality indicators, these are the certain insights about the things that you can actually look into, that your indicators are to be based on standards of care. If you are giving care in a tertiary setup, your indicator should be such that, should be chosen in that way. Community care likewise, and whatnot. These can be evidence-based and derived from the academic literature if available, or when the scientific evidence is lacking, it should be determined by an expert panel of health professionals in a consensus process based on their experience. Well, NABH has done this wonderful job of combining evidence-based, academic literature-based indicators as well as based on the panel of assessors and industry experts. They have also come across some indicators for which academic or scientific literature may not be available but are really, really significant and important in healthcare scenario of India. So that is the best example of indicators. I am really impressed with the third edition of NABH standards, wherein the annexure comprises of 64 set of quality indicators. That is a very good guideline. And when I was giving a presentation to the principal surveyor of JCI, I was actually getting a lot of praises from them for actually referring to the NABH standards and keeping in mind while deciding the numerator and the denominator factors. Now, key characteristics of an ideal indicator should be, it should be based on agreed definition and described exhaustively and exclusively. Indicator is highly or optimally specific and sensitive, that is, it detects few false positive and false negatives. Indicator is valid and reliable. Indicator should discriminate well. You should have your predefined inclusion and exclusion criteria. Indicator relates to clearly identifiable events for the user. Indicator permits useful comparison, and indicator should always be evidence-based as far as possible. Now, there are certain factors affecting variation in indicators. Well, you have to actually keep in mind about the validity and reliability of the indicator data when you are analyzing it. Validity is the degree to which the indicator measures what is intended to measure, and reliability is the extent to which repeated measurements of a stable phenomenon by different data collectors, judges on instruments at different times and places get similar results. In different predefined conditions, Your data is only reliable when it is giving the same result. There should not be data discrepancy. Then only you can call your indicator data as a reliable data. Reliability is important when using an indicator. Likewise, a valid indicator must be producible and consistent. These are certain types of indicators. They are either rate-based or sentinel in nature. They should be related to the structure, process, or outcome. They should be generic or specific, disease-specific wise. They should be preventive, acute, or chronic type of diseases or care they should be tackling to. They should have certain functions of screening, diagnostic, treatment, and follow-up. And either they should be related to the treatment modality like history and physical examination, lab or radiology study, medication, or any other intervention. Well, these are about the rate-based versus sentinel indicators. I would just like to give you an example of a rate-based indicator, that is clean and contaminated wound infection. However, and a very good example of a sentinel event indicator is number of patients who die during surgery. Structure, outcome, and process indicators. Well, structure denotes the attributes of the settings in which care occurs. However, process denotes what is actually done in giving and receiving care. And outcome measures attempt to describe the effects of care on the health status of patients and population. Outcome indicators examples are patient satisfaction, mortality, and morbidity, wherein the process indicators can be proportion of patients with diabetes given regular food care, and the example of a structure indicator can be the number and qualification of personnel employed in the hospital. Now, whenever you are doing indicator monitoring, there should be some risk adjustments. Why risk adjustment is required is because time over? Okay. I have to actually make it very customized for you. I would just like to mention about risk adjustment in evaluating indicators is because one indicator cannot be actually the same, cannot give you the same result in different environments. So you have to keep in mind the different environmental factors while calculating the indicators, and this is the way you can think about risk adjustment. You have to actually look into the patient, nature of patient, the illness, the treatment, and the organization, what kind of constraints or what kind of resources are available in the organization. Now, this is one thing I would like to just end up this session with, is the credibility of indicators. The outcomes may be of major interest to consumers and payers of care, while providers who are receiving data for quality improvement purposes need detailed data about the process of care to make the information credible and possible to act upon, and how standardization of indicators help us in the long run. For the healthy population, indicators can also be important with regard to prevention, quality of life, and satisfaction with healthcare. Well, we all know the satisfaction of level of patients coming to a corporate hospital and a patient going to a public hospital. So, with this, I would like to sum up the topic of standardization of quality indicators. Now, in this group of highly intellectual people or learned members, I would just like to give you a food for thought. Maybe when we'll be meeting next year for sure, I would like you to come prepared with one topic about quality indicator monitoring, that is benchmarking, because benchmarking is the next thing that we want or we need. We right now do not have a database at the national level, or the national agencies who are working for these kind of data collection do not actually disclose it in the way we need it, isn't it? So benchmarking is one thing we want to strive and thrive for in quality. Now, apart from my presentation, I would just like to show you two examples of quality indicator monitoring. Since Josephine ma'am had requested me to actually give you a practical example of what we did. All of you are familiar with this sheet? Maybe some of you, or most of you. These are the set of 11 mandatory indicators by NABH. 5 more minutes, Glory. Have you all seen this sheet? This is the pro forma for monitoring any kind of quality improvement project in JCI. Which one does looks better to you, more informative to you? This one or this one? Any one of you? It has got remarks. It has got the indicator name, the data description, what does this indicator stand for, the traceability or the standard which speaks for itself, the data to be filled, the calculated value, and in the remarks you can actually get to know about the information about deciding how to calculate, what to be excluded, what to be included, how much should be the bed strength and whatnot. So which one does looks more informative to you? This one, or again, let's have a look at what JCI stipulates. JCI talks about performance measure name, the numerator, denominator, the rationale for measuring, the type of measure, the anticipated reporting time, the frequency of assessment, the data collection methodology, the measure target, and whatnot. Which one do you think is more impressive? Rather, sir? Yes. Yes. Exactly, exactly. This is the pro forma given by JCI. Okay? And this is the pro forma followed by all NABH accredited hospitals when they have to monitor their quality indicators. Sir? This is making you? Okay. Okay. And the other one, you have to actually work on it. Isn't it? Okay. Okay.
I'm just saying that it is already predefined over there and it tells me what to do and how to do it and everything is explained.
And this one needs a lot of hard work.
It is little intuitive. I want to be a little sophisticated over there. Little intuitive.
Okay.
More of a dashboard.
Okay, that is more of a dashboard.
This
and
is more
this
of a
one
dashboard,
is,
that is more of an information.
okay, this is more of a dashboard, is it, sir? Well, how about this one? This is one example. Just for the food for thought for you all, I wanted to present to you. There cannot be a debate between a dashboard and a data dumping mechanism because both are not still holistic. When I was preparing for JCI and I presented this with all this holistic approach and information available with JCI and whatnot, they still have not specified what exactly needs to be done. So as sir is saying, somebody who is dumb like me, okay, if he wants to do a quality work or monitor a quality indicator, what that person should do. If you give a lay person like me, I'll get thoroughly confused with this kind of, data preparation. However, this looks quite easy to me. Why? Because this is data dumping mechanism. But let me tell you, there cannot be a comparison between these two. JCI does not give specific data to be monitored, specific quality indicator to be monitored, specific sample size to be monitored. It becomes really vague when you are deciding for the quality indicators and referring to JCI standards. However, NABH simplifies it, but still NABH does not have at the national level benchmarking. So we cannot really actually come up
and
to a conclusion.
international benchmarks.
Yes,
So we have to refer to the national and international benchmarks and
yes,
present accordingly.
Yes, ma'am. CDC, for that matter, is a very good reference that they give for all.
Time up.
Yes, ma'am. Okay. Maybe I have given enough for food for thought to all of
One
you.
comment actually.
Sir.
The word dumb that I used was the spreadsheet that was there, not
Sir.
the person interpreted. Yes, yes. Not the person.
Okay.
It was the spreadsheet.
No more debates now, sir. Thank you very much. I understood you completely. You had been a very patient and wonderful audiences. Thank you very much.